So today I'll be talking about acetabular labral tears in female athletes with hip dysplasia, a critically appraised topic. So my clinical scenario. There have been multiple studies conducted implying that conservative treatment could be beneficial for treating acetabular labral tears. Structural abnormalities are often seen in these patients with labral tears, therefore it is reasonable to assume that conservative treatment may not be effective if hip dysplasia is present. Labral tears that occur in dysplastic hips have an insidious onset because there is no distinctive traumatic event that causes the injury. These patients will likely complain of mechanical symptoms such as clicking, catching, or giving way. The most important step in the physical evaluation is determining if there are any structural deformities present, but these may not be seen until a radiographic evaluation is conducted. So for my focused clinical question, is a conservative treatment or surgical intervention more beneficial for treating an acetabular labral tear in female athletes with hip dysplasia? So to summarize my search, I did a search of scholarly peer-reviewed articles to find studies relating to conservative treatment with the implications of a possible surgical intervention of labral tears in female patients. Most of these studies focused on physical therapy as the conservative treatment. I also searched for how the presence of hip dysplasia relates to acetabular labral tears because this is the focus of my rehab project later on this semester. So the search produced many cohort studies, case series, and literature reviews, and I found only 4 of these articles to use in this project. The first 3 studies used physical therapy protocols, and they were used to address the pain and loss of function stemming from the acetabular labral tear, and surgery was only done if these desired outcomes were not reached. And the 4th study focused on hip dysplasia and the difference in surgical options when taking into account the labral tear. So, clinical bottom line. There is a general consensus that patients should consider conservative measures before contemplating a surgical option, but surgery may be required when a structural deformity is present. There may be inconsistencies in the literature regarding whether conservative treatment is effective when treating an acetabular labral tear, but this needs to be taken into account on a case-by-case basis. Once again, a thorough examination and radiographic evaluation needs to be performed on all patients to better understand their predisposing factors. So with this, I found medium to low quality articles. I could not find a randomized control trial relating to labral tears because they either mentioned femoral acetabular impingement or something that I wasn't actually looking for. The highest Oxford Center of Evidence-Based Medicine level of evidence achieved was a level 3, and I also had some level 4. So based on this, my strength of recommendation is a B. There is limited available quality evidence. So for my PICO, I was looking at female patients or athletes with acetabular labral tears. They either were doing conservative treatment, physical therapy, or surgical intervention, meaning arthroscopy or even for the femoral acetabular osteotomy. And I was looking to reduce symptoms or return to function or return to play. I looked through PubMed and Medline mostly on EBSCO, and I was looking for treatment of acetabular labral tears and hip dysplasia. So my inclusion criteria was a diagnosed labral tear on female patients. They were written in English, and I could get the full text available or request it from the library. And I excluded any systemic reviews, single case reports, reports only on males, studies only on femoral acetabular impingement, or if they were published before 2010. So I found 2 cohort studies, 1 case series, and 1 chart review, being a level 3 or 4 evidence. So I found these to be the best available evidence because of their inclusion of conservative treatment options for female patients with acetabular labral tears. Once again, level 3 or 4 according to the CEBM chart, and I used the Joanna Briggs Institute Critical Appraisal Checklist to appraise the cohort studies and case series. I'll get more into the articles in a minute, but the Articles mostly focused on female patients with a presentation of pre-arthritic interarticular hip disorders. They mostly were active patients, and I also looked at female patients that underwent a periacetabular osteotomy. So, implications for practice, education, and future research. The Hunt and al. Article found that pre-arthritic hip disorders were ones with abnormal articulations between the femur and the acetabulum, and that this predisposes a patient to osteoarthritis, lesions on the chondral surfaces, and the labrum of the hip. They classified these hip disorders by the presence of symptoms of anterior or lateral hip pain, groin pain, pain with weight bearing or pivoting, and positive special tests such as Faber or the straight leg raise. They focused on physical therapy to improve activities of daily living and eliminate irritants, such as pivoting. Some patients requested an MRA, and all of the MRAs done showed a structural abnormality. So I would suggest that this would be a good diagnostic tool for labral tears so you can see the associated conditions that may be involved. Not all patients received a surgical intervention as they were satisfied with the conservative treatment, but more active patients chose the surgery. And the Science and al. Study also reiterated these findings, and they also found that dance, gymnastics, and soccer athletes were more predisposed to acetabular labral tears because of the pivoting motions and repetitive loads placed on their hip during sport. The Yazbek and al. Article had another successful physical therapy program, and they focused on gait training, lumbopelvic stabilization, muscle strength, and sensory motor training. So I believe that these aspects should be incorporated into all rehabilitation programs, whether treating conservatively or post-operatively. The conservative treatment and arthroscopic labral tear may both fail if the underlying structural hip abnormality is not properly addressed. And then I went to discover periacetabular osteotomies have been shown to be effective when treating dysplasia because they correct the functional mechanics of the hip. And Kane et al. Found that these patients, they studied the female patients, they should address the dysplasia before being concerned with the labral tear. There appears to be more benefits in seeking out the periacetabular osteotomy as it can be effective with or without arthroscopy and repairing the labrum. The labral tear or the labral repair alone will only provide short-term relief, as it is likely to reoccur if there is a structure abnormality such as dysplasia present. So we want to focus on the long term, not just the short term. So my clinical recommendation is that each patient with a suspected labral tear or acetabular dysplasia should be considered on a case-by-case basis. These symptoms may vary by patient. Some patients may even be asymptomatic, so a thorough evaluation and imaging needs to be done if possible. Always before beginning the treatment, conservative measures should be taken before considering surgery. More quality research needs to be conducted on the treatment of acetabular labral tears when structural deformities are present, and then more follow-up studies need to be conducted to see how these treatments are providing long-term effects and not just the short term. These are my references. Thanks for coming to my TED Talk.